Arrhythmias, presentation and associated disease. Matt Wright. What is the purpose of history taking? Arrhythmias, ventricular atrial ventricular tachycardia, VD. Ventricular fibrillation, VF. Ventricular premature beats. Atrial fibrillation, AF. Atrial flutter. Atrioventricular nodal reentrant tachycardia, AVNA. Atrioventricular reentrant tachycardia, AVRT. Atrial tachycardia, AT. Sinus tachycardia. Inappropriate sinus tachycardia. Atrial premature beats, bradyarrhythmias, sinus bradycardia, sinus arrest, sick sinus syndrome. Carotid sinus hypersensitivity. First-degree heart block. Second-degree heart block. Third-degree heart block. Key points: age, symptoms, first time or recurrent. Situation, mode of onset. Asymptomatic / syncope / palpitation / chest pain / dyspnea. First time or recurrent. Situation: anger, fright / exercise / sleep / micturition. Mode of onset: gradual or rapid. Mode of termination: with a valsalvis / vagal maneuvers. Drug history: antiarrhythmics / stimulants / antibiotics. Consult the BNF. Toxicity: accidental overdose. Family history: history of structural heart disease. Narrow complex tachycardias. Conduction is via the avenue node and bundle of His. Atrial arrhythmias. Atrial flutter. Atrial fibrillation. Atrial tachycardia. Inappropriate sinus tachycardia. Supraventricular tachycardias. Involves the avenue node. Atrioventricular reentry tachycardia. Atrioventricular nodal reentry tachycardia. Atrial fibrillation. The commonest arrhythmia presenting features: 1% patients greater than 60 years, 5% patients greater than 70 Rs, 10% patients greater than 75 years. Presenting features: may be asymptomatic, vaguely mediated AF, commoner at night, when having a large meal, alcohol binges. Atrial fibrillation symptoms tend to be due to the ventricular response as opposed to AF. Exceptions: mitral stenosis, pulmonary hypertension, palpitations, increased heart rate, lethargy, dyspnea, cardiac chest pain. Features of TIA/stroke. Atrial fibrillation associated conditions: drugs, miscellaneous. Thyrotoxicosis, hypertension, heart failure, valve disease. Drugs: adenosine, digoxin. Miscellaneous: chest infection / surgery / cholecystitis, etc. Atrial fibrillation examination: irregular pulse. At high ventricular rates there may be a pulse deficit. The A pulse at the apex is higher than the palpated rate at the wrist. Hypertension. Absence of A wave in the JVP. Variation of the intensity of S1. Atrial fibrillation. Atrial flutter, a macro reentrant arrhythmia, typical atrial flutter. Anatomical barrier. Zone of slow conduction. Typical atrial flutter. Contained within the right atrium. Constrained anteriorly by the tricuspid valve. Constrained posteriorly by the crista terminalis and eustachian ridge. Travels in a counterclockwise direction around the atrium. Atypical atrial flutters. Counterclockwise flutter. ASD, scar-related flutter. Perimetral flutter. Atrial flutter. Atrial flutter tends to occur in middle-age pulmonary embolism, probably due to atrial dilatation. Pulmonary embolism. Commonly presents with a sinus tachycardia. Associated valve disease. mitral or tricuspid disease, atrial septal defects, chronic ventricular failure, toxic and metabolic conditions, alcohol/thyrotoxicosis/pericarditis, previous ablation, atrial flutter examination. Rarely helpful in establishing the diagnosis. Regular pulse, 150 bpm 2:1, 75 bpm 4:1 can be slower. May see rapid, regular flutter waves in the JVP. Heart sounds. Constant intensity of S1 if relationship of flutter waves to QRS is constant. Carotid massage or adenosine allows flutter waves to be seen more easily. Ventricular rate will increase when SEM is stopped, atrial flutter. Atrial flutter. Of commonest supraventricular arrhythmia. EA dependent upon the avenue node of NR. Normal sinus beat. Initiation of ABNA. ABNA typically third and fourth decade recurrent palpitations. Rapid onset and rapid offset. Patient may feel an ectopic beat to initiate/terminate the arrhythmia. Vagal maneuvers to terminate the arrhythmia. Anxiety/breathless/palpitations. Syncope, due to high rate or due to transient asystole at termination. ABNA. 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 AVRT due to an accessory pathway. Accessory pathways may conduct. Patients can have multiple pathways. Accessory pathways may conduct antegradely, retrogradely. Combination of the two. Wolff-Parkinson-White syndrome. Short PR interval, less than 120 ms. Delta wave. Palpitations and narrow complex tachycardia. Definitions: orthodromic, antidromic, manifest, concealed, latent. Conduction travels in the normal direction, EAA to V. Antidromic. Conduction travels in an abnormal direction, EAV to A. Manifest. An accessory pathway that conducts antegradely. Concealed. An accessory pathway that conducts retrogradely. Latent. An accessory pathway that conducts antegradely, but the refractory period exceeds the sinus cycle length. AVRT presentation: young patient, typically third to fourth decade. May be asymptomatic, part of a medical. Rapid onset and rapid offset. Patient may feel an ectopic beat to initiate/terminate the arrhythmia. Vagal maneuvers to terminate the arrhythmia. Anxiety/breathless/palpitations. Syncope, due to high rate or due to transient asystole at termination. AVRT history of structural heart disease. Family history examination. Ebstein's anomaly. Multiple right-sided accessory pathways. Family history. Higher prevalence in the children, especially if multiple accessory pathways. Examination. Frequently normal. WPW. WPW. AVRT. AVRT. Focal atrial tachycardia. Typically older patients greater than 6 decade. Frequently have structural heart disease, pulmonary disease. Symptoms are related to rate, 120-250 BPM. Underlying heart disease. Rapid initiation. Rate can increase over a few beats as the avenue node warms up. No consistent effect with vagal maneuvers. Digoxin, alcohol/lung disease/metabolic derangements. Focal atrial tachycardia. Regular pulse. Exceptions. If atrial tachycardia is fast, the avenue node may Wenckebach, Mobitz type I. If more than one focus, multifocal atrial tachycardia. Check for signs of pulmonary disease. Cannon waves. Variable S1. Atrial tachycardia. Ventricular tachycardia. May be asymptomatic. Heart rate is not a useful guide to the arrhythmia. More likely if previous history of IHD. Cardiac risk factors. Sudden onset/offset. Is it recurrent? Do they have a pacemaker or an ICD? Family history. Sudden cardiac death. Unexplained death. HOCM/long QT syndrome, Brugada. Physical examination. Is the patient compromised? Assess the JVP. DC cardioversion if any doubt. Assess the JVP. Cannon waves. Assess the precordium. Pacemaker/ICD, median sternotomy scar, LV heave/double apical impulse. Auscultate. Variable S1, ejection systolic murmur. ACG findings. BT regular broad complex tachycardia, QRS greater than 120 ms. Normally RBBB greater than 140 ms. LBBB greater than 160 ms. Evidence of AV dysynchrony. Fusion beats. Capture beats. Concordance. If a 12-lead-in sinus rhythm is available. Q waves, delta waves, RBBB and Saint elevation. Ventricular tachycardia. Ventricular tachycardia. Right ventricular outflow tract tachycardia, VID. Young patients. Athletic. Occur during exercise. Can be terminated by vagal maneuvers. ACG findings. LBBB morphology NV1. Inferior axis. Brugada syndrome due to a mutation in the sodium channel, SCN5A. First presentation may be failed sudden cardiac death. Family history. ECG. Right bundle branch block. Saint elevation in the anterior precordial chest leads, V13. No evidence of structural heart disease. Brugada syndrome. Ventricular fibrillation. No cardiac output. DC cardioversion. Normally cause is evident. Myocardial ischemia. Cardiomyopathy DSM/HCM/HOCM. Torsade depoints and causes of long QT syndrome. Brugada syndrome. Commotio cordis. Summary. The arrhythmia must be seen in the context of the patient, not just the ECG. The state of the patient will depend on the heart rate and underlying heart disease, not the arrhythmia per se. The age of the patient and associated disease can guide the provisional differential diagnosis before seeing the ECG. Examine for signs of avenue dissociation. Key points: age, symptoms, first time or recurrent, situation, mode of onset. Asymptomatic/syncope/palpitation/chest pain/dyspnea. First time or recurrent. Situation: anger, fright/exercise/sleep/micturition. Mode of onset: gradual or rapid. Mode of termination: with a Valsalva/vagal maneuvers. Drug history: antiarrhythmics/stimulants/antibiotics. Consult the BNF. Toxicity: accidental overdose. Family history: history of structural heart disease.